So the role of Washington State spine scope registry data in determining the value of spine care. So I'm a spine surgeon, and every year I kind of go through this exercise where I look back at my cases and just see how I'm doing. How often am I getting a dural tear? How often am I getting an infection? How often do I have to go back to the operating room and do something? Just looking at my complications for my own self-assessment, quality assurance, quality improvement. And let's say in the course of my self-assessment, I've determined that hypothetically I've got a 3% reoperation rate. 3% of the time I'm going back to the OR for whatever reason, infection, hematoma, dural tear, hardware revision. And in the course of my self-assessment, I'm going to ask myself, well, is 3% good or is it bad? It sounds kind of low. 3% doesn't sound very high. And if I look at the literature, well, reoperation rates may range from 2 to 14%. So if I use that, I might say to myself, you know what, I'm doing pretty well. 3% is on the lower end of that spectrum, and maybe I don't need to change what I'm doing. Maybe what I'm doing works. Maybe I'm performing quality service to my patients. But what if all of a sudden I became aware of everyone else's reoperation rates around me? My colleagues, my partners, people at other medical institutions. And what if I found out that the average reoperation rate for all the state of Washington was less than 1%? And what if I found out that that dot up there, that's me, and I'm the outlier, and all of a sudden my 3%, it doesn't look so good anymore. In fact, my 3% is threefold higher than the average for this surgical community of Washington. Well, what would I do if I discovered that was me? Well, first of all, I wouldn't like it. So I would investigate. I would talk to my colleagues. I would talk to my partners. I would talk to people at other hospitals. Hey, what are you doing that I'm not doing? Or what are you not doing that I am doing? Is it my technique? Is there something about my technique that I can improve? Some way that I can change how I'm performing surgery? Are there institutional variables? Is it the system? Is the autoclave broken? Am I doing bigger surgeries, and is that why I'm having a higher reoperation rate? Or is it my patient population? Am I operating on all kidney transplant patients, and that's why I'm having a higher reoperation rate? But the bottom line is I would investigate because nobody wants to be an outlier. Question is, how do I even know? How do I go from this, my own personal intra-institutional self-assessment, to comparing my self-assessment to a community standard or a community benchmark? And the answer is SCOAP, Surgical Care and Outcomes Assessment Program. So what is spine scope? Well, before I can answer what spine scope, I should answer what is SCOAP. It's a Surgical Care and Outcomes Assessment Program. It was founded in 2005 by Dave Flum. Dave Flum is a general surgeon here at the University of Washington, and he and other general surgeons in the state of Washington got together for the purposes of sharing data and sharing the results. The mission of SCOAP is really threefold. Number one is performance surveillance. Number two is benchmarking. And number three is quality improvement, largely focusing on process-based measures. And since then, SCOAP has been expanded to urology, oncological surgery, vascular surgery, and pediatric surgery. And the idea is every quarter, each participating surgeon, each participating medical center will get a report that looks like this. And on the y-axis, this can represent the rate of a complication or the rate of how often you give antibiotics or how often we're doing DVT prophylaxis, basic process-based quality metrics. And then here on the x-axis are all the sites anonymized. You know which site is you, but you don't know who anyone else is, but you can see where you stack up against the community average with the interest of improving quality. And this has been effective in general surgery. So negative appendectomy and imaging accuracy in Washington State SCOAP. A negative appendectomy is when someone comes to the hospital, they've got right lower quadrant pain, nausea, and we make the assessment, oh, this patient's got appendicitis. They go to the OR, we take out the appendix. It's really not that inflamed, and maybe this patient didn't necessarily need to have an appendectomy, negative appendectomy. And what they found is just by sharing data on who gets imaging and how often they get imaging and how often negative appendectomies occur, that they observed a significant increase in the frequency of imaging and a significant decrease in negative appendectomy. And I think we can all agree that's probably a good thing. That's probably good for quality overall in the state of Washington. Now, certain, you're going to hear these terms, and there's an afternoon session on spine scope if you want to learn more about SCOAP. But certain is a little bit of an offshoot of spine scope. This is using the same infrastructure as spine scope, but it's really more focused on comparative effectiveness. It stands for the Comparative Effectiveness Research Translational Network, and it's funded by HRQ and the Washington State Life Discovery Fund. So whereas SCOAP is really more a hospital center, looking at quality metrics, process-based metrics, certain is more patient-centered, looking at the PROMs, the patient-reported outcomes. So what is spine scope? Well, spine scope is a collaboration of all stakeholders in spine surgery, physicians, patients, medical centers, industry, payers, across 20 hospitals in Washington State. And through spine scope, through all these efforts, we're actually at 10,000 spine procedures to date in this registry, which is a huge accomplishment because it took a lot of cooperation from a lot of people willing to share data, willing to be a part of this process. We can look at data on a grand scale like this and see what we're doing, what percentage of our patients have our revision cases, the comorbidity index of our patients, the BMI of our patients, we can see what we're doing for lumbar procedures. And we can see that about a third of our cases are roughly lumbar decompression without fusion, decompression with fusion, and fusion alone. Well, we can get more granular than this. We can see who we're operating on and for why. What percentage of our patients actually have neurological symptoms that we're performing a lumbar fusion on? And we can see, again, anonymized, where we stack up relative to the SCOAP benchmark. We can see what percentage of our patients are smokers. You know, it's widely believed that smoking is a risk factor for a poor result in pseudoarthrosis. And across the board, 20% of lumbar fusion cases seem to be in smokers. And is this an area that we as a community, as a surgical community, can improve upon just by sharing these data and discussing amongst ourselves? We can look at operative processes. Perioperative blood sugars among diabetics. We know that blood sugars, perioperative blood sugars have been associated with surgical site infection. And we can see how well we're monitoring these data. We can see how often we're using insulin for glucose over 200. Again, you see a wide spread here compared to the benchmark. And just by looking at this, we can see how we stack up against our peers and colleagues. Some metrics may not be as useful. You know, surgeons tend to use X-ray verification for a surgical level, and this is something that we've been measuring. And because SCOAP is physician-driven and the metrics committee are all physicians, surgeons, well, you know, we may decide we don't need to waste resources looking at this metric anymore because we all seem to be doing pretty well. This is kind of self-selecting. What about postoperative metrics? Well, we can see how often we're continuing beta blockers postoperatively, and we're doing pretty well in this area here as well. Now here's where we get into some granularity of the data, postoperative complication. Now, of course, we have to define complication and what that means, and then we can define it more in the afternoon session, but here it's essentially referring to the unplanned ICU admission, infection, cardiac complications, neural complications, urinary complications, and anemia. And we can see how we rank relative to the statewide benchmark. We can look at our reoperation rates here as we showed before. Length of stay. You know, Joe talked about length of stay being a metric of immense interest to not only payers but also medical centers and, of course, patients and physicians. And we can see how we stack up. Now, these data here are not necessarily risk adjusted, and there's a whole other talk on risk adjustment coming up shortly, but that's something that needs to be addressed as we go forward. We can get snapshots in what we're doing. Posterior lumbar fusion. You know, BMP has been a hot topic in the news recently. And we find that in the state of Washington, in posterior lumbar fusion, we're using BMP about 25% of the time as a state community. And we can decide if that's good, if that's bad, if that's too much or it's too little. But the point is we can look at these data and make improvements and move forward. Anterior cervical fusion. You know, BMP is contraindicated, but BMP is still occurring in 2.5% of the cases here. So just by sharing these data, if I'm one of those people who's using that, I can see how often everyone else is using it, and maybe I need to change my technique. But where we get into value is really with patient-reported outcomes. Again, that's certain. And this is where SCOAP is expanding. The SCOAP infrastructure where we can have abstractors pull out data from various medical centers. When we start recording patient-reported outcomes, as we are recording patient-reported outcomes, these data can be abstracted as well. We can look at ODI, NDI, VAS, health-related quality of life scores. But imagine using this infrastructure where we can get preoperative scores and postoperative scores. Postoperative scores at 2 weeks, 2 years. And that's going to be discussed a little bit more in the afternoon session today. But that's where we're going with SCOAP, is with a certain process so we can enhance our value. Is what we're doing works? Are patients actually getting better from it? Are we seeing a functional improvement? The importance of this is threefold. Number one, research. We can look at things like, well, the influence of something like BMP on patient-reported outcome. You know, we know that BMP works pretty well for fusion, and there's all sorts of discussion on safety profile, but how does it affect outcome? But not everyone's interested in research. So most importantly, we want to demonstrate the value of surgery. Does what we do work in terms of return of function, pain resolution, and a return to work? And better patient selection. I think all of us can agree that not all patients do well with a lumbar fusion, and maybe it's just a matter of patient selection and patient optimization, getting patients healthy before surgery. So when we think of value, you know, Dr. Bellabarba had a great presentation on value. It's kind of a hard concept, but essentially it's quality as a ratio against cost. Quality against cost over time. And when we think about the spine SCOAP organization and the certain organization, clearly there's value there in terms of improving what we do, how well we do it, and what kind of a return we can get to the patient. So you just saw the slide here. What is value? Value is quality against cost over time. And that time component is pretty important. You know, the value of a surgery postoperative day 1 is much different from the value of surgery postoperative day 365. conceptually, they're easy to kind of wrap our heads around, but when you get down to the nitty-gritty, it really gets kind of tough to define value. We know, what is cost? Cost to who? Cost to you as a patient? Cost to me as a physician? Cost to the society? Do you include direct costs, indirect costs, long-term costs? And along the same lines, what is quality? You know, quality can be what you make of it. Quality can be process metrics. They can be patient satisfaction scores. They can be health-related quality of life scores, VAS scores, or they can be complications. And where I want to go with this presentation is really in complications, because I think we can all agree that complications have an impact on not only on quality, but also on cost. And this has been the focus of a lot of our research here at the University of Washington. So complications, nobody likes them. Patients don't like them, physicians don't like them, medical centers don't like them, and insurance companies don't like them. But we all kind of don't like them for different reasons. The reason why a patient doesn't like a complication may be very different from the reason an insurance company may not like a complication. As we go forward in this presentation, I want to focus on complications in two realms. The first is the safety of surgery, which is first and foremost of importance. If we understand complications, if we anticipate complications, we can better treat complications, we can better counsel our patients, and engage in more of the shared decision-making, which is a big buzzword in research these days. So that's the first and foremost reason why we study complications, is to enhance the safety of what we do. But the second reason is policy structuring. You know, increasingly, complications are being regarded as a metric of quality. DVT, surgical site infection, readmission. When these things happen, there are direct results. There's financial penalty, and how do these policies affect how we do it and how we go about with our healthcare? So first, let's talk about the safety of surgery. So we've done a fair amount of research in this area, and it's focused on two areas. The first area is identification and quantification of risk factors for complication. And this really focuses on how sick the patient is and how big the surgery we're doing. And that kind of makes sense. But then also talk a little bit about predictive modeling. So this is a patient of mine. And if I told you this is a 50-year-old patient who's got kyphosis, back pain, otherwise healthy, you can see she's had a Harrington rod placed decades ago, and we know now that these patients will often develop a flat back syndrome. You might say to yourself, well, this is a patient who would benefit from some kind of corrective osteotomy and extension of fusion. But what if I told you this is a 75-year-old patient who had kyphosis and back pain, but also had osteoporosis, history of an MI, and history of a stroke? We can make her x-ray look better, but how well is that patient going to do? This patient may not necessarily be a candidate for such a large invasive procedure. What if she didn't have a stroke, but it was just history of an MI and osteoporosis? Now, is she healthy enough to undergo that surgery? Or if she just had osteoporosis and she was 75 years old, now is she healthy enough that you would consider going for a large osteotomy procedure? That's the focus of this presentation. The first question that we surgeons make is this a patient where surgery is indicated? Is this a patient where I'm willing to do a surgery on? And the patient on the left, we may not, and the patient on the right, we probably would. And the second question is, how much surgery? You know, there are different ways to do what we want to do. To correct spinal alignment, we can do a pedicle subtraction osteotomy. You could do multiple Smith-Peterson osteotomies. You could do a vertebral column resection. And the point is, within surgery, there's a spectrum of surgical invasiveness of how much surgery we can do to a patient with varying amounts of correction, varying amounts of risk. And of course, in the back of our mind, what we're all thinking is, how well is this patient going to do with surgery? What's the likelihood for complication? And of course, this is actually a 50-year-old patient who underwent the pedicle subtraction osteotomy L4. Even though the metal looks kind of funny, you can see her sagittal balance is otherwise restored. So complications have been studied before. We've used large national databases, the Medicare databases, the NIS databases. And the advantage of these data registries is there's large power. You can look at thousands of patients, hundreds of thousands of patients at once. But we have to be careful in how we interpret these data registries. These are not surgery-specific data registries, and there's limitations in the information that they provide. For example, the NIS data registry only looks at the index admissions. So if you're studying complications, patient goes home, shows up in your office with a complication, that complication is not captured. So you might be underrepresenting the actual rate of complications. So we have to be aware of the relative weaknesses of all these registries. But that being said, you can get a lot of power. This is an example of such a study. This is actually done here at the University of Washington, the morbidity and mortality in association with operations on the lumbar spine by Rick Dale. 18,000 patients from the state of Washington Hospital Registry. 18,000 patients. When was the last time we did a study on 18,000 patients? And they found that risk factors for morbidity and mortality were age, degenerative diagnosis, and arthrodesis. But again, the problem with a registry like this is we don't get enough surgical granular data. You know, this kind of data registry doesn't differentiate a laminectomy and a fusion from a laminectomy and a fusion. And if you look at these two x-rays, clearly there's a different risk profile with these two procedures, but it doesn't account for that in this kind of a registry. So differences in surgical invasiveness are not accounted for. Now we can go to the opposite end of the spectrum where we can get as much surgical data as we want. This is, again, out of JBJS in 2003. Perioperative Complications of Posterior Lumbar Decompression in Older Adults. And this is a retrospective case series. And here you can go back in the chart, dig around, get as much surgical detail as you want. But you can only do that so many times. And here they had 78 patients, far different from the 18,000. And they found that age was a significant risk factor, but they admitted that their numbers are too small for any kind of meaningful statistical analysis. So what is the ideal study? Well, an ideal study would be prospective. You'd want large numbers, maybe not 18,000, but still certainly more than 78. And you'd want extensive comorbidity data recorded up front. You'd want extensive surgical detail recorded up front, all prospectively. And you'd want your complications all defined in the beginning and recorded for at least 2 years. And such a data registry does exist. It's actually here at the University of Washington, the Spine End Results Registry. This is established by our former partner, Dr. Sohail Mirza, with the help of some NIH grants and a Synthes Spine Endowment. This is a prospective registry of all surgical spine patients over a 2-year period from 2003 to 2004. A total of 1,745 patients, and extensive data was recorded all up front. It was a monumental effort. These are just some examples of some of the risk factors that they recorded before any kind of surgery was done. The absence or presence of gender or smoking status, alcohol abuse, drug use. And I'm not going to go into the whole thing because these aren't even all of them. But I do want to highlight this, surgical invasiveness, because that's something that's really lacking in most registries and something that we don't take account for with our analyses. So this is the idea of Dr. Sohail Mirza. It's a surgical invasiveness index. It's a point scale which quantifies how much surgery you've had done. And it's been validated in the literature. So essentially, you assign a point for every level arthrodeced, every level decompressed, and every level instrumented, either from a posterior or anterior approach. So you have an anterior cervical discectomy and fusion. Well, you got 1 discectomy, 1 point for anterior decompression, 2 vertebrae arthrodeced, and 2 vertebrae instruments, so a total score of 5. Now we can put a number value on a single level ACDF, and now we can quantify it and we can control for invasiveness. So if I want to compare the results of an ACDF for a posterior C1 to C5 laminectomy and fusion for OPLL, I can compare a number 5 to a number 14. And this invasiveness scale has been validated in the literature in regard to OR time and blood loss and infection. This is kind of a busy slide, but this is just to point out the level of detail that this registry really went to. I mean, in terms of cardiac complication, you can see it's not just someone in a back room saying, oh yeah, we'll call it a cardiac complication. There are explicit criteria and thresholds and definitions of these complications. And this is done for pulmonary complications, dural tear, GI complications. In total, there are 176 complications that were all defined before any data was even entered into the registry. So it's a pretty high quality registry. And you can imagine from this registry, we've published fairly extensively looking at risk factors for complication after surgery. The first 2 on cardiopulmonary complications. This one's the JBJS for surgical site infection. This one's for dural tear in the NASS journal. And of course, looking at medical complication in spine and the NASS journal as well. And these have been pretty well received in the literature with some positive commentary. At the end of each of these studies, you're going to come across a chart that looks like this. You can see a chart with risk factors for different kinds of complications, relative risks, p-values, and confidence intervals. And from a statistical standpoint, this is great. From an academic standpoint, this is great. You could publish this till the cows come home. You can add lines to your CV. You can get promoted from assistant professor to associate professor. This is great for academics. But at the end of the day, we have to ask ourselves a question. What is the practical utility of a chart like this to a patient? How often do we go into a patient's room and talk to them about relative risks and odds ratios and confidence intervals? And the truth is, we don't talk to patients about relative risks and odds ratios and confidence intervals because, frankly, they have a difficult time understanding it. And frankly, we as physicians have a difficult time understanding it and translating it to patients. So patients don't come in asking about relative risks and odds ratios. They ask, doctor, what are the chances I'm going to have a heart attack if I have this surgery? Doctor, what are the chances I'm going to have a surgical site infection if I have this surgery? Doctor, what are the chances I'm going to have some kind of a complication if I don't go into surgery? And to answer that, we need a predictive model. Now, as a second part of our research effort is to create and validate a predictive model for the safety of spine surgery. Predictive models are nothing new in medicine. Those of you closer to the cardiac side of things may recall the Revised Cardiac Risk Index. This is a model which predicts the likelihood of cardiac event with any kind of surgery based on the absence or presence of a number of risk factors. And that's what we try to do with spine surgery. We try to create a predictive model by just looking at the age, the absence or presence of a whole series of risk factors. Can we give patients an absolute likelihood of complications so they can use that in their decision making, so we can use that in our decision making, so we can enhance the safety of surgery? That's exactly what we did. I'm not going to bore you with the details of the methodology, but I will say that we looked at major complications and all medical complications, the major ones being things like heart attack, PE, and things that are more likely to result in permanent harm. This is just statistically how we measure it with the ROC value, and the ROC value for any medical complication is 0.76, and I'll talk about what that means in a little bit. ROC value for major medical complications was 0.81, and that's just how we measure the accuracy of our predictive model. If you open up a statistical textbook, you'll come across terms like fair to good, and probably be scratching your head the same way I was. But if you look at the revised cardiac risk index, the ROC value is 0.77, and this is highly regarded. This is widely used in medicine, and our values are pretty close to that. So it suggests that the accuracy is pretty good for predictive models. Now, of course, we had this complex formula that no sane person in their right mind is going to memorize or keep in their back pocket or whip out during clinic. So we created a website called spinesage.com. It's freely accessible, and the idea is that this can be perhaps used as a decision-making guide. We just put it out there because we thought it was a good thing to do. So for an example, let's say if I have a 65-year-old man with rheumatoid arthritis and diabetes considering surgery, either a laminectomy or a laminectomy and post-lateral fusion or a laminectomy and a 360-degree fusion. I can go to SpineSage, enter in the age, in all these drop-down menus, enter in the absence or presence of various risk factors. When I get to the bottom of the page, I hit this Generate button, and I come across a page that looks like this. Now, this is kind of busy, but I'll take you through it. So this is specific for that particular patient, that 65-year-old male with rheumatoid arthritis and diabetes. The blue represents the likelihood of major complication. The green represents the likelihood of all complications. So you can see if this patient is going to undergo a single-level laminectomy or a surgery with a surgical invasiveness score of 1, and there's a key here for that, you can see the likelihood of major complications 1.69%, the likelihood of any complications 9.26%. And you can see how this changes based on the varying levels of surgical invasiveness. We also did this for infection. I can tell this patient their relative risk or the likely risk of surgical site infection. Again, this is not everyone. This is a 65-year-old male with rheumatoid arthritis and diabetes. And with single-level laminectomy, the likelihood for surgical site infection was actually as high as 7.03%. So that's been our research effort looking at complications. I want to go into policy structuring a little bit because it's really important, talking about quality metrics. So we all know quality metrics are out there. There's hospital-acquired conditions deemed by CMS. And in the event of a hospital-acquired condition, there's a quality adjustment payment. Basically means if we have complications, medical center is not going to get paid. There's a financial penalty. You know, as we stated before, these quality metrics, similar to those large registries, don't account for surgical invasiveness. You know, there's no due process. If you have a surgical site infection, there's no one sitting at CMS saying, oh, well, you know, this patient did undergo a T10 of pelvis fusion and he is a transplant patient, so we're going to cut him a pass. There's no due process. It's across-the-board cuts. So these quality metrics don't account for differences in complexity of surgery or surgical invasiveness. Similarly, these quality metrics don't account for different patients. The patient on the left is much less likely to have a complication than the patient on the right, even though they are the same person. So what can happen? I mean, if these quality metrics go on as planned, what is a possibility? Is it possible that we might start selecting against patients with risk factors for poor outcome, against patients who are at risk for having complications or being readmitted, sick patients, patients who need large surgeries? Is there a possibility that we might select against them and further widen disparities in healthcare? That's where something like this, maybe not exactly SpineSage, but a risk adjustment model or a predictive model like SpineSage can be useful. We can maybe level the playing field a little bit. We can risk adjust for these presence of risk factors or large surgeries. But we have to be careful when we talk about risk adjustment because it's kind of a tricky business. You know, it's one thing to risk adjust for scientific factors like comorbidities or surgical invasiveness. But what about other things that can affect outcome? What about socioeconomic status? You know, in the medical literature, socioeconomic status is associated with higher morbidity and mortality. There's nothing politically correct about that statement, but if you're a healthcare provider, you know that's true. We all know that's true. In the orthopedic literature, we've shown that socioeconomic status is significantly associated with higher rates of readmission. Medicaid status, significantly associated with higher rates of readmission. This is something we published in Spine. Medicaid status is associated with high rate of complication rates after spine surgery. This is actually in submission right now. Medicaid status associated with high rates of surgical site infection after spine surgery. Twofold higher likelihood of surgical site infection as compared to non-Medicaid patients. How do we incorporate something like socioeconomic status and risk adjustment? How do we, and talking about widening disparities in healthcare, will these quality metrics have an unintended adverse effect? We've already got patients with risk factors, sick patients, patients needing big surgeries, but how do you account for something like socioeconomic status? It's not like there's a clamor to embrace the Medicaid community anyways. You know, 40% of physicians don't see any Medicaid patients. So, you know, while we're improving healthcare coverage, what about access to care? How is that going to be affected as we move forward with these quality metrics policies? I don't have the answer, I just wanted to ask the question. So, and that's the end of the presentation. Thank you.
And I'm going to talk about 17 years of experience doing various spinal procedures with tubular retractors and some of the things I've learned in the process. Minimally invasive spine surgery is the same rationale as any other minimally invasive surgical procedure, whether it's OBGYN, general surgical, arthroscopic. The idea is to try to reduce the collateral tissue damage while you achieve the same goals as the counterpart open procedure. And no matter how you do this, there are certain elements that you need to incorporate to try to remain effective. So you've got to have an approach portal. Of course, by definition, it's small because you're trying to minimize that approach-related morbidity. Because you've got these small approach portals, you've got to have some form of magnification and illumination incorporated into your procedure. You also need some kind of supplemental localization because you can't physically visually see all of the surrounding anatomy. And there are issues with that, including the important issue of surgeon orientation. And then there are some specialized tools that become necessary, again, if you're going to try to achieve the same goals as the counterpart open surgery. And again, the goal is to reduce tissue trauma and at least short term have the same results as the counterpart open surgery. And maybe there are some long-term benefits to reducing tissue trauma. The basic principle is that if we cut you more, we hurt you more. The major issue here is that can we get the job done, number one, and number two, does it really make a difference? So this efficacy aspect is equally, if not more important than the ability to perform the procedure. And one of the things that led me down this pathway was my experience with some of the other minimally invasive approaches to spine surgery, including some of the very small cannulae. When I was a young neurosurgeon, Joe Maroon was popularizing a minimally invasive technique that early on looked like it might be of value. I actually tried that technique and was disappointed with the kinds of results I was seeing clinically. So early on learned the lesson that minimally invasive can't mean that you're being minimally effective at the same time. So Joe wasn't the first to try doing spine surgeries in a less invasive fashion. Actually, the first person that can probably be credited is J. Lawrence Poole, was a neurosurgeon at Columbia, chairman of the department at the time, and he adapted a battery-operated cystoscope back in the 30s into a procedure he called myeloscopy. He actually used it for diagnostic rather than therapeutic purposes under local anesthesia. So over the years, a lot of attempts to minimize the invasiveness of spine surgery. Chymopapine, some of the folks who are my age in the audience and above will remember this described back in the 60s by Lyman Smith. Actually, when I was a resident at UCLA in the early 80s, finally got its FDA approval. And I remember one day we had all of the neurosurgeons and all the orthopedic spine surgeons in a training course at UCLA, and forward we marched. And of course, we learned some lessons there over the years. Arthroscopic discectomy, followed by the procedure that Joe Maroon early on popularized, the so-called APLD. And the foraminoscopy and laser-assisted techniques get popularized even to this day. So the problem with a lot of these techniques, and at least what I ran into, was that I could not achieve the goals that I could routinely achieve if I did the procedure in an open fashion. And there were certain pathologies that I felt like I could not address. Well, and we know that some of these things just don't work yet. As much as they're popularized and advertised, they don't work as well as an open discectomy. So my goal early on was to try to combine a less invasive approach with something that actually worked. Could we do both things? And a very simple concept was to grow that little cannula a bit. Tubes made sense to me. It turns out that they minimize and evenly distribute the intramuscular pressure around them. You can make them extremely thin-walled, and even when they're quite long, 9 or 10 centimeters, they'll maintain their structural integrity, whereas blades have to grow thicker as we make them longer, otherwise they deflect into our surgical field. So I thought there might be some utility there. And after a couple of years of work in the lab, did the first tubular discectomies in 1996. Mo Smith was my fellow at the time, and we published our early experience in 1997, a little over a year later. And our parameters for measuring outcomes have obviously changed massively over the past couple of decades. Good and excellent results by McNabb criteria now just don't cut the mustard anymore. But we thought we might be seeing something good here. And so this is a typical case where even though there was a large free fragment, we indeed felt and could remove that large free fragment and with minimal disturbance of the muscle and something that was reasonably cosmetically appealing to patients. So we began to teach this to others, a group of early adopters who came down to Memphis to learn. Rick Fessler was one of the early adopters as well. In fact, we wrote up an expanded series with Rick's group that we published in Neurosurgery in 2002. And again, thought we were seeing results roughly equivalent to what we could achieve with regular microdiscectomy. And so lots and lots of publications on this over the years, and we've learned some things. Raj Rampersad up in Toronto looked at very early results in a comparative study of tube discectomies versus open microdiscectomies, looking at what went on in the early postoperative period, including in the recovery room, and found a reduced pain and narcotic use by patients and shorter hospital stays. A couple of years ago, I published a consecutive series of patients in the hands of someone who had been doing it for 10 years. So I began accumulating that data, that particular series in 2007, and just for reporting purposes, that was 274 patients with 287 operated levels. You see the levels there and the demographics, and again, mainly unilateral decompressions, some bilateral decompressions, a potpourri of things done. But patients, all of whom had failed non-operative management, required some kind of decompressive procedure in their lumbar spine. And when I do this through a 16 millimeter tube. All of these have done, since the inception, done them as day surgeries. So they go out the same day. I've had, over the years, very few patients stay overnight. In this particular series of 280-something patients, had one overnight stay, was a patient with a dural tear. And if a dural tear occurs for me, they stay overnight and go home the next morning. And so just a how to do it, many of you are familiar with this, it's a paramedian approach, and it's a paramedian approach because you're trying not to detach the multifidi from the spine. And you have to localize that approach, and after an incision is made and just into the subcutaneous tissues, the fascia is penetrated with a K-wire, and sequential dilators establish that plane in between intact muscle fascicles, but again off the midline, so you're not detaching the multifidi and not damaging them. Down go sequential dilators and goes your tube. And at this point, you're doing a microdiscectomy. You're just using a different retractor with an off-axis approach. And you can decompress the nerve root, number one, and then confirm that the nerve root has been decompressed. When I trained at UCLA, although I'm a neurosurgeon, I did a 6-month fellowship with Ed Dawson, who ran the complex spine surgery service on the orthopedic service at the time. And Ed used to call this an SOS, or satisfying orthopedic sensation. So so I'll call it an SNS. It's both. But again, done, you know, I published these pictures years ago. I think lots of people put coin pictures out there now. So small incision. But the point is that the accomplishing the goals with inexperienced hands, a small complication rate. And the other thing is that the improvement in the patient-derived outcomes, the PROMs, those improvements are equivalent to what we would see with open discectomy, unlike anything else that's been shown with so-called minimally invasive procedures. Other minimally invasive approaches to discs have not shown equivalent outcomes to microdiscectomy. Again, the same data in graphical form. Over the years, lots of study of this issue, and probably the definitive study was carried out by Mark Arts as a neurosurgeon in the Netherlands, and this was the subject of his PhD thesis, and got the government to fund a very large, comprehensive, randomized prospective trial of tubular discectomy versus open microdiscectomy, and didn't find a statistically significant difference between the two techniques. The outcomes were statistically a dead heat. So if you look at the statistically significant differences between the two groups, one difference was that when the surgeons used the tube, they tended to use the microscope a lot more. When they did an open microdiscectomy, they tended to use loops a little bit more. And that was reflected a little bit in their speed. So 47 minutes on average to do a tube discectomy, 36 minutes to do a microdiscectomy with loops. I wouldn't quibble about that. Both of those times I think are perfectly acceptable. That turned out to be a statistically significant difference. What wasn't different were the ultimate outcomes, nor were the complication rates. Absolutely no difference in complication rates between the two groups. And these are the curves showing, the Kaplan-Meier curves showing the outcomes over time. And again, if you look at the statistics, the groups were statistically identical in terms of outcomes. So what Mark basically proved is that, yep, you can achieve identical results in terms of nerve root decompression through a tube as you can if you do an open microdiscectomy. This is a meta-analysis that Dazenbrock published in 2012, looking at a number of the different studies that are out there. And again, found that there was a substantial and equivalent improvement in leg pain in groups treated either with microdiscectomy or tubular discectomy. And there were not, although there were in his study a few more durotomies in the tube group, the overall complication rates did not vary. So over the years, with finding the utility with decompression of the lumbar spine, of course, there was a natural tendency to see if this tool might work in other places, and this is just a list of some of the other places where that approach has been looked at. I published this paper back in '99, dating me a bit, looking, Mo was my partner at the time, and Raj Ramprasad was my fellow, looking at using this approach for far lateral discectomy, using an approach about 4.5 centimeters off the midline, which eventually led to the approach for minimally invasive TLIF. But you can kind of see the trajectory that the tube takes for that. And that's where you want to be. Again, to get oriented here, and because you have to dock on bone, I aim for the pars of the nerve root that is the compressed root. So, for example, if it's an L3-4 disc, I dock my tube. I land on the pars at L3 because I want to identify that L3 root at a place where I know it will exist. It has to exist as it exits that foramen adjacent to pedicle, and then follow it down to the disc herniation. So, and we should have a short video of what goes on there. So you can see this is very magnified. There's the root coming out here. Disc spaces across, that's medial, that's lateral. Apologize for the quality of the video. But the disc space is running transversely across here, root, and more importantly, the dorsal root ganglion sit right there. And again, you're using it as a retractor, but using it as a retractor with again, minimizing, hopefully, the damage to those paraspinous tissues, but able to not only, I think, effectively decompress the root, but importantly at the end, confirm that you actually got the job done. So here at the very end, I'll take a ball probe once I remove the disc fragments here and confirm that that root is indeed decompressed. So there's the DRG, and I'm just taking the ball probe as we would do in an open surgery and confirming that, yes, it's free. I've accomplished my surgical goal. It was natural to take the tube and start looking at other decompressive lumbar surgeries, as I talked about in my series a bit earlier, and so it was expanded to use in stenosis cases, and the first people to publish on that almost simultaneously were Sylvan Palmer and Larry Koo and Rick Fessler. The technique was using the tubular retractor, but really recapitulating a technique that Young had first published in '88, and then John McCullough had popularized very shortly thereafter, basically undercutting the other side of the canal from a unilateral approach in an attempt to minimize tissue injury. Young and McCullough were doing it in an open fashion, and we were simply doing the same thing through the tube. And I'll run through the technique slides here quickly. Basically, an oblique approach across, and this is kind of a money shot to show you. You've done your unilateral decompression. I'm working across the midline. It's not that far over, and then I'm palpating the contralateral pedicle to ensure that I indeed have crossed the midline and decompressed everything that I needed to. And here are some pre and post images to show you what you can accomplish through that unilateral approach. This is a physiatrist from Iowa who came down with he was the fellow with the 2-level stenosis. And again, I could do this open too. He wanted to have it done with a little less tissue trauma. And just to show that is indeed doable. Same thing for cervical nerve root compression from soft discs or foraminal stenosis. Again, just placing the tube in a paramedian position in the cervical spine. This is a shot of the exiting root here, working underneath it to retrieve some disc fragments that were compressing the root. Midline is up here, lateral is here. It's caudal, this is cephalad. This fellow had a few disc fragments producing the radiculopathy. I don't know if, yeah, there's even one more. And of course, he could have an ACDF, he could have an artificial disc, but this, if doable, is a procedure that saves your motion segment and is a lot less expensive than either of those procedures. Done for years in an open fashion, but also very doable using a tubular retractor. So the first person to publish on that was Tim Adamson. Tim was one of the fellows who came down to Memphis early to learn the techniques. And there have been other publications since. I just referenced Tim because he was the first guy to publish on this. And he published his first 100 cases and showed the routine ability to be able to reliably decompress patients and get them home very early after posterior cervical discectomy. This was in 2001, and I think it was unique at that point to be able to think that you could send posterior cervical discectomies out a few hours after surgery. And his follow-up data, again, old outcome metrics, right, from over a decade ago, was equivalent to what one might see with a well-done open posterior surgery. It was a natural evolution to go from the decompressive procedures to looking at whether or not reconstructions could be done using a similar approach. It required the development of some different solutions for placing percutaneous screws, reference there, but really what enabled it was the ability to have these extenders on the screws. Percutaneous screws had been described by Mogrel back in the 90s for trauma, but with a big external apparatus that he had to use to hold those screws together, like any orthopedic fixator. It was the fixator extern, and so we basically internalized that. So we published on those surgeries early on, and the first minimally invasive fusions were done, again, a little over a decade ago. So this is one of my early cases. This is actually a standalone ALIF that I did in one of the trials. This was a non-BMP patient, and she did well for about 6 months, and then came back with increasing pain, and you can see why. It's a classic non-union. Well, one of the reasons she had wanted an ALIF is she was very proud of this tattoo she had and didn't want anyone disturbing that. So this is a posterolateral onlay fusion done through the tube with instrumentation to stabilize her, and I think we accomplished her goal of saving her artful tattoo. This was one of the early spondy cases that I did through the tube. Before we had any specialized implants, this was done with shaped allograft, but again, done effectively through 2 little incisions. Wong's series are looking at 85 consecutive patients undergoing open TLIF or minimally invasive TLIF. He found that OR time and clinical outcomes and fusion rates were identical, but the minimally invasive TLIFs had a lot less blood loss, and that's been borne out over a number of studies. Blood loss is clearly less with these procedures. That does result or translate into fewer transfusions and short lengths of stay. In terms of whether or not fusions can be effectively accomplished in this fashion, I think Roger Hartle's group has answered that pretty definitively with their meta-analysis referenced here, published in Spine back in 2010, and found comparable fusion rates. These are the kinds of studies we need to see more of to see whether or not this is really true. But it speaks to the fact that as we move from less invasive things like microdiscectomy to more invasive things like interbody fusion, that perhaps the minimally invasive techniques, the effective minimally invasive techniques, are going to have some quantifiable advantages in terms of cost. And there have been lots of variations on the theme. And so those have been used to take tube-type approaches and use them for different approaches to the spine, whether you're coming laterally or anterolaterally or even anteriorly. We've also learned that there are challenges to these techniques, and I think one of the biggest things holding back the field is the difficulty in performing these surgeries through these small portals. Ian Kalfas, who's at the Cleveland Clinic, likes to tell me, "Oh, Kevin, you're doing ship-in-a-bottle surgery." I think, yeah, you're right. I'm working through a bottleneck to get to a bigger place. And so that does impact orientation and ergonomics and your ability to visualize. And I think it leads to difficulties with the learning curve. And there's no question there's a learning curve to these procedures like there is to any new task you're trying to learn how to perform. And of course, we all think the learning curve is smooth, right? We start out and we move right into that upper zone here. Of course, that's not true. You wax and wane for a while until you get better. What I can tell you, though, is you can't learn this in a weekend course. It takes some practice to learn how to do this. That's another lesson learned. But I'd conclude that there are a variety of procedures that can be effectively accomplished using tubular retractors. And properly done, these procedures can be safe and effective. There's no question there's a learning curve. And I believe the use of this approach will continue to evolve. Thank you very much.
When artificial disc technologies first sprouted in the US in 2000, there was a fundamental question, and that is, can the same problem, this degenerated disc disease that's causing functional disability, be treated with interventions that seem to be exactly opposite? Traditionally, we had treated that by locking that level up, taking away all the motion and saying that'll make person better and take their pain away. Now we're saying, let's make that level mobile and let it start moving again, and that will take the pain away too. So intellectually, there was a little difficulty getting our minds around that, and that's one of the key questions that I think the data will show. But why was there even an interest in changing from fusion? I mean, why would any surgeon say maybe there's something better? One of the reasons is there was a disconnect between radiographic fusion rates, which were getting better and better due to better instrumentation, better techniques, biologics. We can get fusions now in over 90% of our patients radiographically, but we've never bumped the outcome of fusion from about 67%. That's the same as it was with uninstrumented fusion. That's what it is with instrumented fusion, and that's what it is with technically better instrumented fusion. So that was one of the reasons why many of us were interested in looking at that other way of possibly treating this phenomenon. The other was adjacent level disease. We all understood that by fusing a segment, we are going to negatively affect adjacent levels. Patients would always ask, what's the risk? And reviewing the literature, most of us would say you probably have about a 30% chance in 10 to 15 years that your next level will degenerate and may require surgery. That's sort of a pretty good average. And lastly, because we're in a new era now of medicine, we had to ask the question, can we be cost effective? Can we achieve similar or better results for the same or less money with this new technology? So those were the three issues on the table. As Mike mentioned, artificial disc theory goes back a long way. The first patent internationally really was in France in the 1950s. And this gentleman had the idea of putting spheres or discs in the disc space that later turned into the Fernstrom ball example, which was placed, as you know, in patients. And you can see by this x-ray that there's significant subsidence. There's a lot of point pressure. And just that was not a good practical application of what may have been an interesting idea. These were implanted and patients did not do well. The modern era of arthroplasty really came in the mid-'80s from East Germany, and that was with the Charité. The initial implant, the Charité 1, was a little bottle cap. It was revised about a year afterwards because of subsidence issues with some lateral wings to spread the pressure a little bit along the end plates, and ultimately became the Charité that was tested through an FDA IDE in the United States and has been sold worldwide until 1 year ago. The US experience, as I said, began in March of 2000. One of my partners, Scott Blumenthal, implanted the first one here in the US. They had a multi-center study of 196 Charité patients. FDA approval came in year 2004. This was sold again commercially worldwide until 2012, when it was discontinued by Johnson & Johnson DePuy. The ProDisc was developed independently by Thierry Marnet. Thierry is a French deformities orthopedic surgeon, and he came up with the idea for the ProDisc in the late 80s, and that was still during the Cold War. There was not a lot of academic communication between East Berlin and southern France. So his idea developed independently of Karen Buttner-Jans. Thierry developed this implant, put it in 64 patients, and then let them sit for a while. He wanted to see what the results were. And it evolved ultimately into a slightly different design when the results of those patients at 7 to 11-year follow-up were actually quite good. Those results were shown to the FDA, and they very quickly approved this version of the ProDisc for an FDA study to begin in the US. The history in the US was the first implant was done in September 2001. 296 patients were studied at 17 centers, FDA approval for single-level use in 2006. The 2-year data has been published in 2007. The 5-year data was published in 2012. So this cohort of patients has been followed, and the adjacent level data has also been published, and I'll share that with you. Since then, there are lots of other lumbar discs that are available outside the US, and there are several of these pictured that are in various stages of the FDA pipeline. But at this point, the only lumbar disc that's commercially available is the ProDisc, whose data I'll show you. And some of these have not made it very far in their cycle. As far as cervical arthroplasty, the legacy discs have been around since the mid-2000s, the Bryan disc, the Prestige, stainless, and the Protis. They've been around since 2006 or 7 as FDA-approved devices. Just within the last year, these additional devices, Secure C by Globus, PCM as the new invasive device, and the Mobi-C have now gotten FDA approval. So there's a little bit more room in the cervical space for competition. Kineflex C was a device that's a metal on metal, and it's a victim of the metal on metal uproar that's around now because of peripheral joint arthroplasty. And although that study was completed and the data was about to go to FDA panel, they withdrew it actually because of the negative environment right now for metal on metal. There's a Prestige metal on metal implant that's, I think, available outside the US. And the M6 disc is interesting. It's an American company who decided to only sell outside the United States and not spend the money to do an IDE study. It's kind of disappointing. It's a popular disc in both cervical and lumbar applications outside the US, but not available to us here. But let's turn a little bit and talk about the future of spine surgery because of the change in outlook now in medicine. Our future to be able to deliver good care to our patients is really going to be very data-centered, and it's not this data. It's this data. It's the data that comes from a lot of work in the trenches. People who are following patients with us, making sure all these forms get filled out, making sure that someone's responsible for them. And when the FDA comes calling, it's like an IRS audit. They work for the same company, and somebody is looking at every single line item, and the doctor is the guy who's responsible ultimately. So let me show you the data that's been generated by these studies, and this is really good, high-quality scientific evidence. This is beyond case reports or case series or retrospective analyses. These are prospective, randomized, multi-center trials. Many people think because they're industry-sponsored that they are less valid than anything else. But the expense, the amount of money that is required to generate these studies, none of us can bear this as an individual. And the NIH, the government, has really gotten out of the business of studying commercial implants. And so the next best thing is the new paradigm is that the companies pay for it, but the government oversees it. And that's not a bad way to do it. As taxpayers, we get a lot more bang for our buck that way. And the oversight is significant. None of us wants to go to jail. None of us wants to lose our license. None of us wants to, have a felony attached to us for fraud. So the oversight is a pretty significant cap that overlooks all these studies. The lumbar population, as I showed you before, were 286 patients. The 75 fusions randomized to 161. And a lot of people, when these studies started, were rightfully concerned about new technology. And their concerns were these 4 things I'll share with you. One is that indications would be stretched, that instead of 100,000 fusions done in the United States, there would now be 200,000 operations because surgeons would figure out another 100,000 ways to use this new technology, as we had done somewhat with cylindrical cages, which unfortunately became very popular, expanded indications, and had failures because we didn't really understand the biology and the mechanics. So the repeat of this cage rage was a real concern. The second was, would there be a higher rate of perioperative complications? You need a direct anterior approach to put a lumbar device in, whereas with a fusion, if you can't mobilize the vessels over, most of us can do a pretty good job coming in obliquely. There are ways you can cheat. There are lots of different implant choices. You don't need an absolute anterior approach, meaning to take all the vessels over to the right. So people felt that these devices, because of that requirement, might result in higher perioperative complications. A third concern was that these mobile devices would break down or subside or expel and require increased revisions. A fusion, once it heals, shouldn't have to be approached again, yet these devices were complete unknowns. So the third concern is, will you be having to go back to the anterior spine with significant vascular complications? And the last one was outcomes. Is this going to be more hype than, more hype than hope? Because you're taking a fusion, which has been in the literature for 50 years, has lots of publications, is a very known entity, and now we're introducing some brand new device that has no track record. Even in Europe, it had only started a couple of years before in the lumbar spine. So these were the four concerns, and again, these were legitimate concerns. But this was year 2000, and now we're in 2013, and we have the ability to analyze these and look back with the benefit of data analysis and long-term follow-up. As far as indications go, there was a big surprise waiting for the DePuy folks when the Charité was approved, because up until that point, FDA approval automatically meant that insurance companies would pay for the device. They'd reimburse for it. That was a given. When the Charité got approved, many of the insurance companies refused to approve its use, saying that they still considered it experimental and investigational, despite the FDA. Very soon after the Charité and ProDisc were FDA approved, CMS weighed in, and again, this was a population that was mandated by labeling between 18 and 60, so it was really not a device for Medicare population. But Medicare still gave it a non-coverage decision, which then went on to influence the indemnity carriers. Soon after that, a Blue Cross Tech assessment, which looks at new technologies, wouldn't approve it. The earliest insurance approval, interestingly, was with Aetna, which may have been because the 140,000 worldwide J&J employees were insured through Aetna. So Aetna was the first indemnity carrier to allow this. Cigna joined them. Blue Cross Blue Shield over several years grudgingly approved it in about 5 states, and it was only within the last several months that Blue Cross approved nationally lumbar arthroplasty, even after all these years. United Healthcare still hasn't approved it. Workers' compensation, whose data who should have been overwhelmed by the earlier return to work data, has never really embraced it. The coverage has remained very spotty. And just 2 weeks ago, out of the blue, Aetna, which was the first company to approve the device, and now in the face of only positive publications, has reversed it, and they now consider this experimental and investigational, and as of 2 weeks ago, will no longer cover lumbar arthroplasties. But as a consequence of that, since the FDA approvals, most of these devices have been done on label, because the insurance companies who would grudgingly approve it will only approve it on label. So there's not been any expansion of use, largely because of that cap that's been put on utilization by insurance. If we try to get an arm around the denominator, the companies keep these numbers pretty close to the vest. So right before the Charité was pulled from the J&J website, they said that there were between 25 and 30,000 lumbar Charités implanted worldwide. Synthes website similarly states only that there are just greater than 40,000 worldwide ProDisc implantations. I think these numbers are conservative, but no one's releasing any better numbers. There are others that are sold outside the US, as I showed you, and no one has good numbers for those. So if we look, there's a global denominator that's a minimum of 70,000 patients. It's probably more likely 100 to 100 plus thousand. So the bottom line being, there's a lot of patients who have these lumbar devices in and have had them implanted since year 2000. There's been no suggestion by the insurance industry or the government of expanded incidence of anterior lumbar procedures. So although the major deterrents to volume have really been insurance approval and reimbursement, we have not seen that explosion. So the first great concern of stretched indications and a repeat of the cage rage really has not evolved. It hasn't come out at all. As far as perioperative complications, the nice thing about these IDE studies is that the patients were kept in a box. So we have very good data on perioperative complications because both of the Charité and ProDisc studies tracked their operative complications closely. Both studies reported fewer perioperative adverse events in the arthroplasty patients than in the fusion patients. And there was no indication that this new technology was causing an increase in the acute perioperative period. This is just from the 2007 publication, again, showing very low amounts of complications. And again, these were good surgeons and everybody knew that they were under a microscope, so maybe people were being a little bit more careful. But I'll show you a little bit of real-world data in a sec. So as far as the second concern, we haven't seen an issue with higher perioperative complications. Well, how about revisions? How about these devices failing and having to be revised? In the 286 patients that were in the randomized ProDisc IDE study, 2.8% required revision versus 5.3% in the control patients in the first 2 years. In years 3 to 5, an additional 3 ProDisc patients and 6 fusion patients, for a total revision rate of 4.3% in the arthroplasty patients and 13.3% in the fusion patients were identified. And these, again, are very high follow-up rates, 98% for the 2 years and 82% for the 5-year patients, don't show that difference in reoperation rate. But these were for the randomized patients. There were additional waves of continued access patients before the device was approved. The surgeons who were investigators were allowed to do more procedures, but they had to follow the patients the same way. That was the deal. There were a total of 1,094, which included the randomized and non-randomized patients. What about the revision rates in those patients? 3.5%, or 38 out of 1,094 patients. But in that 3.5%, 2/3 of them, or 27, were much less risky posterior procedures. They were foraminotomies for nerve root pain, dorsal column stimulator for patients who had more diffuse pain or a battered root, and 1 or 2 patients who had fusions for persistent back pain. Only 11 patients out of the 1,100, or 1%, required anterior revisions, which is really what the fear was. And of those, there were no catastrophes. No patients died, and there were no major vascular issues. So in this second population, that's a bit expanded, but still among the same surgeons, we didn't see any large increase in revision rates. Well, how about after commercialization? When it's out in the real world now, when it's out of the hands of just the 34 investigators, in the first 1,000 cases that were done when the ProDisc was FDA approved and surgeons started training, the revision rate, the anterior revision rate was 0.36%. Again, arms around all these patients, because even if a different surgeon had to take the device out, he had to call the company to get equipment and would generally talk to one of the investigative surgeons to find out how to get it out. So, there's essentially no likelihood that there are many who were done by outside surgeons that we've not captured. Well, now how about in the 1,300 surgeons that have been trained since 2006? In all the ProDiscs that have been done in the US, the revision rate is still less than 1%. So we're very comfortable that, at least in the years that we're following these patients now, that we're not seeing a very big bump in revision rate. So our third concern has not really panned out. Our last one comes down to the outcomes, and we have very good data now on the outcomes. Again, our 2-year data was published with a 98% follow-up rate, and our 5-year data with an 82% follow-up rate, and it's a lot of work. As Dr. Foley said, somebody needs to chase these patients down and make sure it gets done. Prior to this study, we did a quick analysis in the English language spine literature. The average follow-up rate at 5 years was about 55%. And not a lot of papers track patients. None of them were multi-center prospective. Most of those were single-center prospective studies. So we thought 82% was a pretty good number. So let's look at the 5-year outcomes. Now, before we go there, the key points at 2 years were that the ProDisc was shown to be safe and effective. That's how it got labeled by the FDA. That 94% of the patients still had ranges of motion at that segment within a normal range, and that the patients were more satisfied, actually more satisfied than the patients who had single-level 360 fusions, and all that led to single-level FDA approval. And this is published, it's been in the literature for quite a while. But how about looking at the same issues now, in addition, looking at adjacent level degeneration, because now we've followed those patients out for 5 years. And we published this two different times as an overview in Seminars in Spine Surgery last March. But the big 5-year outcome was in December 2012 in the Journal of Neurosurgery. And this is the VAS that I showed you briefly before when we looked at just for an overview, you can see the numbers stay very solid in years 3, years 4, and years 5. We don't see any uptick, so that the patients who get their 50 to 60% improvement very soon after surgery maintain that improvement in both groups, whether they have a single level fusion or single level arthroplasty. It's nice to see, again, there is a value to surgery in the appropriate patient who has failed conservative care. We now have really good, solid, prospective, multi-center data to throw back when people say to us, prove to us that there's some value in what you do. The same thing with the ODI. There's a significant improvement. I showed you the 24-month data. Here's year 3, year 4, and year 5. Again, significant improvements that are maintained very solidly out to 5 years. So the bullet points at 5 years were all the patients were studied again. That 82% follow-up rate included all the centers, all the patients, and all the surgeons. That the improvements in VAS and ODI remained very stable out to 5 years. Overall reoperation rates, as I showed you, remained low and remained no worse than fusions, which are fairly low to begin with. And that the anterior reoperation rates, the ones we really were worried about, were extremely low. And in the ones that were necessary, there were no disasters, although we treat those all very seriously. And that, again, patient satisfaction remains high out to 5 years. For a chronic back pain population, that's a pretty good thing. And remember, this is good stuff. This is very high level scientific data. The holy grail of arthroplasty, that really important point was, would we see a difference in adjacent level disease or degeneration? One is radiographic, one is clinical. And honestly, although we decided to study it with our 5-year data, I did not expect to see a difference in 5 years. I thought the difference would be in the 5 to 10 or even the 10 to 15-year interval. Because we had the data, we did look at it at 5 years. And we published this also as the second article after the 5-year outcomes in the Journal of Neurosurgery. The study design hinged on the fact that all the x-rays were digitized and were sent down to medical metrics. So they had all the digital data down there. So we said to the radiologists down in medical metrics, hey guys, look at the pre-op film and then look at the 5-year film. We don't care about the films in between. And we said to them, we want you to look at these 4 parameters: at loss of disc height, end plate sclerosis, osteophyte, and translation, and just assign them a point value. So do it to the pre-op film and do it to the 5-year film on each patient. And we asked them to report those differences to us as a delta ALD, a delta adjacent level disease. So we didn't care about the absolute. I just cared about the difference between the pre-op film and the 5-year film. So for example, if a patient had a 1 on his pre-op film, if he had an osteophyte, and he had a 3 on his 5-year film, he had some disc height loss and some translation, then his delta ALD was 2. He had worsened by 2. If his score preoperatively was 2, if he had an osteophyte and some sclerosis, and he had the same thing at 5 years, his delta was 0. So we tried to really make this relatively simple because that's all we were interested in. What's the difference between pre-op and 5 years? So here's what we found. In the patients who had a single level, so a patient who had a post-laminectomy disc space collapse, that was their degenerative segment. Every other level was pristine. In those patients, new findings of an adjacent level radiographic degeneration were found in 23.8% above a fusion and in 6.7% above an arthroplasty. And remember, these were patients who were just externally randomized. We had nothing to do with randomization. They were the same coming into the study. That difference, that's a 3-to-1 difference, which is very highly statistically significant. Now, not every patient had pristine discs everywhere else. All they had to have was a single symptomatic level. Some of these patients had an adjacent level that was degenerated but not symptomatic. So we culled those patients out. In those patients, a change in the adjacent level was found in 28.6% above a fusion, but again, in only 9.2% if they had an artificial disc. So even in the patients who had some pre-existing degenerative disease, they had also a 1/3 chance that their adjacent level disease had changed for the worse. And that again was highly statistically significant. Adjacent level surgeries were done in about 4% of the fusion patients, in 2% of the arthroplasty patients, but in very small numbers, which were not statistically significant. So the conclusions that we could make is if you start with an adjacent level that's normal, you're 3 to 4 times more likely to acquire a radiographic degeneration if you've had a fusion at single level rather than an arthroplasty. And in all patients, you're still 3 times more likely to get adjacent level degeneration after a single level fusion, all other things being equal. We were worried about poor outcomes. We didn't get poor outcomes. We got good outcomes, and we got the bonus of adjacent level protection. So we've got good level 1 data to show you, as I said, with single level functionally disabling disease, surgery can be very effective whether you have a fusion or an arthroplasty. So no evidence of stretch indications, low perioperative morbidity, very low revision rates, and very good solid outcome data through 5 years, and improvements in their adjacent level. So we're very happy with our lumbar arthroplasty. We think science should win out. We should get better numbers as additional IDE studies come through and are published. The demand, I think, from patients will increase because patients are smart. They do a lot of research. And insurance company approvals up until 2 weeks ago, when Aetna reversed the decision, were getting better and better. And comparative effectiveness should help us. I mean, this is strong data. This is sort of what the government was looking for. Let me show you that we saw very similar findings with our cervical arthroplasty data. Again, a multi-center prospective study, this time looking for patients with single-level cervical radiculopathy, not just mechanical pain. Pivotal study was published in 2009 for 2-year, and the 5-year paper was printed just this year, published this year in Spine. Follow-up rates at 2 years were very high again. At 5 years were about 72% for the PRODUCE patients. At 7 years, again, this is new territory. We've never had 7-year follow-up on spine patients. We're down to that mid-50s range where traditionally we had seen 5-year follow-up. So it's harder and harder to track patients even when you have a company behind you doing it. But you know, the data is what it is. You can see neck disability index, tremendous drop that is maintained again out to now 7 years. VAS for arm pain maintained out to 7 years. We're not seeing an uptick. We're not seeing that we've lost the advantage. Neck pain that is secondary to radiculopathy improves in parallel with the improvement in arm pain. Range of motion is maintained out to 7 years. Patient satisfaction remains very high out to 7 years. 100% of the arthroplasty patients at 7 years said they would have that surgery again. 91% of ACDF patients. Very, very high numbers, very good for surgeons whose customers are these patients. Secondary surgical procedures, again, a very significant difference. 16% of the ACDF patients had needed secondary surgery, only 5% of the PRODUCE patients. Again, a little bit of a surprise for us. So we see stable neck disability index rates, stable VAS for neck and arm pain, range of motion maintained, and a 3-to-1 difference in arthroplasty. What the FDA studies have done for us is they've taught us the discipline of doing a prospective randomized study. They've made us scientists and not just technicians. They've given us this very strong scientific basis that we can advise our patients on, and very valid long-term outcome measures. So they've done good things for us. They've let us give better advice to our patients, be better advocates for our patients against governments, against payers, and against people who are naysayers. And you know, I think we've learned a lot by being forced to be good scientists, and we've gotten very good ammunition. Thank you again. Thanks for your time.